There are 6 things that we need to know about H. pylori gastritis. The first thing, let us learn about the anatomy of the stomach. Stomach has cardia, fundus, body, pyloric part, and then the intestine continues. So the cardiac and pyloric part are very similar in the sense that they both have mucus producing epithelial cells, but the difference is the pyloric part has G cells which secrete gastrin. The thing about gastrin is that it is a hormone and it can stimulate chief cells, it can stimulate parietal cells, and it can also secrete neuroendocrine cells, which is enterochromaffin-like cells. The second thing is the fundus and the body. The fundus and the body also have mucus-producing epithelial cells, but they also have chief cells and parietal cells. Chief cells secrete pepsinogen, and the parietal cells secrete HCl and intrinsic factor, which is helpful in absorption of vitamin B12. Now, the 2 most important things we need to know about H. pylori are, number 1 is that it loves to infect the antrum, and second thing is that it cannot survive in the intestinal epithelium. Now, the interesting thing is the person, when a patient is presenting with duodenal ulcer, most commonly, they are infected by H. pylori. So why is this happening? So the reason is that H. pylori cannot survive in intestinal epithelium. It cannot also survive in acidic environment, but what it can do is that it can secrete urease. Now this urease will convert urea into ammonia. Then this ammonia is alkaline, so it will increase the pH of the stomach so that it becomes less acidic. Now the G cells in the pylorus will sense this increase in pH and it will secrete more gastrin. Now what this gastrin will do is that it will travel to the fundus and it will stimulate the parietal cells. These parietal cells will secrete HCl, which will increase the acidic content. Now this happens, the HCl is increased in a large amount during this scenario. That is why it will damage the mucosal epithelium of the stomach, which will lead to ulceration of the antrum and duodenum. Now, does there no occurrence of ulceration in fundus and body part? I'm not sure, but what can happen is that in prolonged infection, prolonged inflammation, in chronic condition of inflammation, this infection can travel to the fundus and the body part of the stomach, and what it can do is that it will obviously cause damage. Now the response of the stomach mucosa of the fundus body part will be that it will undergo metaplasia, it will undergo intestinal metaplasia. Now the interesting thing, or the serious thing about intestinal metaplasia is that it will damage the fundus and the body part. Before going to intestinal metaplasia, what happens is that it destroys the parietal cells present in the fundus and the body. It won't fully destroy all the parietal cells, it will destroy patchy destruction of parietal cells. That means some parts of the parietal cells are still present and normal, which will be secreting acid in less amount. So this less amount of acid secretion will again be sensed by the G cells in the pyloric part, and it will secrete gastrin. Now this gastrin will again go to the stomach fundus part, and then it will urge the remaining remnants of the parietal cells to secrete HCl, but again less amount of HCl. So this less amount of HCl is not going to make that balance, so it is not sufficient, so ulcer will not survive. So there will be no occurrence of duodenal or any kind of ulcer present in there. And since ulcer does not survive, it will undergo metaplasia, intestinal metaplasia, and this intestinal metaplasia can convert into gastric adenocarcinoma. This is the serious part of this. So we can understand that there is an inverse relationship between gastric adenocarcinoma and duodenal and pyloric ulcer or whatever. So we can say that if there is duodenal ulcer present, then there probably won't be gastric adenocarcinoma, and if there is gastric adenocarcinoma present, there probably won't be duodenal ulcer. This is the inverse relationship. If you go towards the mode of transmission, it is transmitted from human to human. it isn't normally infected to people below 10 years. From 18 to 30 years, 10% of the population are infected, and mostly more than 65 ages of people are affected, and it is transmitted by fecal-oral route. And once you are infected by H. pylori, you will probably stay with yourself for until lifetime, until and unless your whole stomach has undergone metaplasia so that it cannot survive in the intestinal epithelium. Okay, now this is the mode of transmission. If you go towards microscopic part, then we know that this H. pylori only infects the mucosa layer of the GI tract, and in the mucosa we have muscular mucosa lining, we have lamina propria, we have muscularis mucosa, mucosa muscularis, and there are three types of things we need to notice in the microscopy. Number one is H. pylori in the mucosal lining. There is mucosa, there is basement membrane, there is lamina propria, there is muscularis mucosa. In this mucosa lining, on the top of the mucosa lining, in the depressions like that, H. pylori are present, and lymphocytes and plasma cells are present in the lamina propria. And the neutrophils are present in three locations. Number one, they are present in lamina propria. Number two, they are present in intraepithelial locations. So it will traverse through the basement membrane and it will get stuck there, intraepithelial locations. It will again traverse to the basement membrane into the glands. It will go into the lumen of the gland, so it is found in the lumen. Three location: lamina propria, lumen, intraepithelial location. This is that. Now, in serious chronic cases, what can happen is that normally in the stomach, lamina propria, there is no lymphocytes and plasma cells in large number. But in this scenario, in chronic conditions, not only there will be large number of lymphocytes and plasma cells, there will be primary and secondary follicles, which is not present in the stomach lamina propria. So when you see this in microscopy, you will term it as tertiary lymphoid organs. The other examples are thyroid gland in Hashimoto's thyroiditis, salivary gland in Sjogren's syndrome. And the thing is that it can progress to extranodal marginal zone lymphoma of stomach. So basically, at the end, the H. pylori gastritis can cause duodenal ulcers, stomach ulcers. It can cause gastric adenocarcinoma. It can cause lymphoma, extranodal marginal zone lymphoma.